Okay, Assalamualaikum warahmatullahi wabarakatuh. I'm going to teach you about rhythm recognition. So rhythm recognition is very important in managing of advanced cardiac life support patient because every single rhythm have their own treatment, and then you need to follow based on what algorithm lah, either pulseless or asystole, either tachyarrhythmia or bradyarrhythmia. So in this lecture, we will show you the common rhythm that you need to know, the characteristic and the sign of the rhythm based on the ECG. We not discuss about the treatment because the treatment is depend on the patient condition, whether the patient is stable or unstable. So before we discuss with the abnormal rhythm, we need to know what is the normal ECG or normal cardiac wave. Okay, this is normal ECG or normal cardiac wave. So usually the normal ECG should have P wave, Q, R, S or QRS complex, ST segment, T wave. And then sometimes you can see U wave. So there's some interval we need to know also. First is the PR interval, then second QRS complex. Either QRS is narrow or broad, and then the third one is QT interval. This one is we need to know, but very rare we discuss in the advanced cardiac life support. The most important is PR interval and QRS interval. So how we want to know whether the PR interval is prolonged or QRS is narrow or broad? That's why we need to know the ECG paper or electrocardiogram. So in ECG paper, we have big box and we have small box. So one big box contain of 5 small box on the x-axis and 5 small box on the y-axis. So x-axis represent duration or the time of the cardiac activity, and then y-axis represent the current or the electrical or the voltage of the ECG wave. Okay, we go to the x-axis first. So the time and the duration is very important, like I mentioned just now, because we want to know whether the distance of the PR or the QRS complex is prolonged or not. So one big box represents 0.2 second. So one small box is about 0.04 second. So for PR interval, the normal PR is usually less than 0.2 second, 0.2 second. So we take from the starting of P until the starting of R wave. So normal PR should be less than 0.2 second or less than 5 small box. So in some condition like first degree heart block or any second or third degree, the PR usually is prolonged, more than 0.2 second. Then we look for QRS complex. So normal QRS complex, I mentioned just now, is less than 3 small box or less than 0.12 second. So for the narrow QRS complex, it's less than 0.12 second. Broad QRS complex is more than 3 small box or more than 0.12 second. For the example, in broad complex tachyarrhythmia such as of VT, so we can see the QRS complex is broad. Okay, next we go to the y-axis, which is voltage of or current of the ECG wave. So this axis is important also because we want to look whether the ST segment elevation is significant enough to diagnose as acute ST elevation MI, or sometimes we want to see whether the ST depression is significant or not. So for the example, in acute ST elevation MI, based on the ECG, the diagnosis is the ST segment elevation, this segment, is elevate more than 0.1 millivolt or more than one small box in two contiguous lead. At least for lead V2 and V3 is slightly different. Next component in ECG interpretation is the heart rate. As we know, the normal heart rate of the patient is depend on the origin of the electrical cardiac activity. So in normal individual or normal patient, the heart rate is origin from the SA node. So the rate is about 70 beat per minute. In some condition, the patient can develop junctional or the patient can get the original of the electrical cardiac activity from the junctional, either in between the SA node or AV node lah, or near the AV node. It is about 60 beat per minute, the rate. And some condition, the patient may have electrical activity originate from the ventricle. The rate is about 40 beat per minute. Next, you need to know what is the definition of tachycardia and bradycardia. Tachycardia is when the heart rate is more than 100. Bradycardia is when the heart rate is less than 60. So next we want to know what is the rhythm, and then we will discuss one by one what is the rhythm, the characteristic of the rhythm, and this is about all the common algorithm that we need to know in the advanced cardiac life support. It consists of normal sinus rhythm, tachyarrhythmia, and also is bradyarrhythmia. Okay, first we go to the normal sinus rhythm ECG first. So what is the characteristic of the normal sinus rhythm? First, we can see that the normal sinus rhythm must have P wave followed by the QRS complex. And second, we must see that the P and P interval must be same. Okay, P wave and P wave, the interval is same. Then the RR interval also same. And then the third characteristic, we must look for the PR interval. This is P wave, origin of the P wave, and then this is R wave. So PR interval must be normal less than 5 small box or less than 0.2 second. So as we know, one small box is about 0.04. So it is about one big box. So the normal PR interval should be less than 0.2 second. Next is the normal QRS complex. So the normal QRS complex should be about less than 0.12 second, or about 3 small box. So this is normal QRS complex. And then another characteristic of the sinus rhythm, it must be within the normal heart rate or less than 100 but not less than 60. Okay, this is normal sinus rhythm ECG. Okay, this ECG we cannot miss. This is quite classical of atrial flutter. So we can see it is characterized by sawtooth appearance. So you can see the atrial rate is very fast, about 300 beat per minute. So this is classical sawtooth appearance. Usually the atrial flutter is due to re-entry circuit at the right atrium. So the atrial will contract very fast, and then the ventricle also will contract normally lah. So this one is 3-in-1 block of the atrial flutter. Okay, next is atrial tachycardia or supraventricular tachycardia. This ECG also very important when patient presented to you with palpitation. Usually patient presented with palpitation, sometimes giddiness, then sweating. So when this ECG we call atrial tachycardia or supraventricular tachycardia. So it is characterized by sinus tachy, and then the narrow QRS complex, less than 0.12 second, and then sometimes the tachycardia is very fast until we cannot see the P wave. So the P wave is embedded in T wave. Okay, this is supraventricular tachycardia. Okay, next is atrial fibrillation. So this is ECG of atrial fibrillation. So the characteristic of the atrial fibrillation is we cannot see any obvious P wave, and then the interval of the RR is also different. The RR interval is different. It's not same. Okay, this is unifocal atrial ectopic. So from the ECG you can see there is presence of abnormal P wave in between the normal PQRS complex. Okay, this is another P wave, this is another ectopic P wave. So the unifocal atrial ectopic is due to originate from the atrial. The ectopic originate from the atrium. Okay, next rhythm is sinus with premature junctional complex rhythm. So the characteristic of premature junctional complex rhythm is you can see presence of abnormal QRS complex without P wave. So this is another premature junctional complex rhythm. So this rhythm is basically originate not from SA node, that's why you cannot see the P wave. It is originate from the area between SA node to the AV node or nearby the AV node. Okay, this is idioventricular rhythm. So as you can see from this ECG, so the rhythm is originate from the ventricle. So you only can see the QRS complex without P wave. This is because the rhythm is originate from the ventricle itself, not from the SA node. Okay, this rhythm is commonly seen especially after the patient after CPR or patient post reperfusion arrhythmia. Okay. Okay, this is another abnormal rhythm. Okay, this we call unifocal premature ventricular complex. Okay, as you can see from the ECG, you can see there's presence of abnormal QRS complex or abnormal ventricular complex in between the normal P QRS complex. So as the name is premature ventricular complex, so this rhythm is originate from the ventricle itself. So you cannot see the P wave before the QRS, abnormal QRS complex. Okay, next is sinus with multifocal ventricular complex. So this rhythm is slightly different compared to previous unifocal ventricular complex. Okay, as you can see from the ECG, you can see abnormal QRS complex, but different morphology. So that's why we call multifocal ventricular complex. So that means the ectopic beat is more than one point at the ventricle, not single. So this is normal PQRS complex, and then you can see the premature ventricular complex, and then there is no P wave because the rhythm is originate from the ventricle. Okay, next rhythm is multifocal PVC with bigemini. So compared to previous ECG, this one we can see the premature ventricular complex is quite common. Every single normal PQRS complex alternate with abnormal PVC, normal, abnormal, normal, and then another abnormal PVC but different morphology. So that's what we call multifocal PVC by Gemini. Okay, that means the ectopic bit is from the ventricle, but there's more than one point of ectopic bit. Okay, this is another ECG of premature ventricular complex, but this one we call couplet of unifocal PVC because we can see there is presence of two consecutive premature ventricular complex and the morphological is same. So that's why we call couplet unifocal PVC. Okay, this is another important ECG. This is we call ventricular tachycardia or broad complex tachyarrhythmia. So as we can see from the ECG, the QRS complex is very broad, more than 3 small box, and then the ventricular rate is very fast, it's more than 150. So this is one of the shockable rhythm. So if you got the patient with this kind of ECG, you need to check the patient whether the patient have pulse or pulseless. So because the management is different. Okay, this is the most important ECG, which is ventricular fibrillation. The characteristic of the ventricular fibrillation is very rapid, wide, and irregular ventricular complex. So you cannot see any obvious QRS complex. And this is the most important ECG lah. When you saw the patient with this kind of ECG and then the patient is unconscious, so you need to immediately deliver defibrillation or shock. Okay, next ECG is first degree heart block. Okay, the important characteristic of the first degree heart block is you can see the PR, P, the R interval is prolonged, more than 5 small box or more than 0.2 second. And then of course the rate is less than 60. So this is first degree heart block. This is quite common, especially in athlete, and then sometimes can presented in patient increased vagal tone, and then sometimes in MI patient. Then this rhythm usually patient is stable, unlikely cause hemodynamically instability. Okay, this is ECG of second degree heart block. Okay, Mobitz Type 1. So the most important characteristic of Mobitz Type 1 second degree heart block is prolonged lengthening of the PR interval. So as we can see from this ECG, okay, this is first PR, slightly prolonged, and then the second PR is more prolonged, and then the third one is more prolonged, and then the fourth one there is no more QRS complex or drop beat. Okay, so again the most important characteristic of Mobitz Type 1 second degree heart block is prolonged lengthening of the PR interval. Okay, this is another example of second degree Mobitz Type 1. So same, you can see prolonged lengthening of the PR interval, and then suddenly we got drop beat or no QRS complex. Okay, next rhythm is second degree heart block Mobitz Type 2. So compared to Mobitz Type 1, this Mobitz Type 2, usually the PR interval can be normal. That means less than 5 small box. Okay, normal PR, but you can see there is presence of P wave and then not followed by QRS complex. So that means there's no conduction at the ventricle, only at the atrium. So PR interval is normal, and then P not followed by QRS complex. Okay, this is Mobitz type 2 second degree heart block. Okay, next rhythm is complete heart block. Okay, the complete heart block happen is due to completely loss of atrial and ventricle association. That means block at the higher degree. So from the ECG you can see the atrial rate or the P wave is regular, P to P is regular. Okay, and then the QRS complex or RR interval is regular rate. So this ECG, the atrial rate is about 100, the ventricular rate is about 40. Okay, this is complete heart block. Complete heart block, usually patient is can presented with dizziness, syncope, then patient usually unstable and may need pharmacological or electrical pacing. Okay, this is another important ECG and another group of tachyarrhythmia, which is polymorphic, ventricular, tachycardia or Torsade. So the ECG, as you can see, the ECG is the QRS complex is very wide or broad, and then the amplitude is irregular, and then you can see the R wave twisted. Okay, so this is Torsade. Okay, next rhythm is paced ventricular rhythm. So in paced ventricular rhythm, you can see the pacer mark, then followed by the QRS complex. Pacer mark and then followed by QRS complex. So you can see this type of rhythm in patient with pacemaker or after you put the patient on pacing. Okay, this is another ECG of ventricular fibrillation, but this one is fine VF. So if you see this type of ECG, so you need to increase the amplitude of the you need to increase the size at the cardiac monitor so that you can confirm this is ventricular fibrillation. Okay, this is another example of coarse ventricular fibrillation. So as you can see, the QRS complex wide, broad, and irregular, and then the amplitude is sometimes low, sometimes high. So you cannot miss this kind of ECG of VF. Okay, this is his last rhythm. This is asystole rhythm. So you cannot see any electrical cardiac activity. So either the patient is truly pulseless, or you need to check all the equipment, whether the cardiac monitor is properly attached to the patient or not. Okay, if all the equipment check is correct, so of course the patient is asystole, it's no pulse.